Hello, and welcome to another edition of From the Source COVID-19 Pandemic Edition. I'm Elizabeth Johnson, bringing you the latest information on the pandemic. There are a lot of questions surrounding this disease. For those who don't know, the coronaviruses are a type of virus. There are many different kinds, and some cause disease. A newly identified coronavirus, SARS-CoV-2, has caused a worldwide pandemic of respiratory illness called COVID-19. I had the opportunity to speak with Dr. Gribbin, an internal medicine physician who's on the front line in New York City, to help us better understand COVID-19. What occurs when a patient is hospitalized, and answers to a number of questions regarding the pandemic. Welcome, Katie. Thank you very much for joining us today.
Thank you for having me.
Well, our viewers are very interested in what it's like to be on the front line, especially on the COVID team. I know that you just graduated from Weill Cornell a year ago, and they placed you on this team. Can you tell me a little bit about what you do and what your day looks like?
Sure. So I'll start off by saying that basically all of our internal medicine teams right now are COVID teams because it's just so prevalent in New York. And as an internal medicine resident, basically what I do in the hospital is admit people to the hospital and then take care of them as their main doctor while they're there. So the intake and the admissions, there's a lot of triaging that happens. So basically assessing how acutely sick someone is, figuring out when it comes to COVID, how much of that is related to COVID. And obviously these days, a lot of it is, versus other problems that might be going on. Oftentimes this kind of stuff happens overnight. A lot of people come into the hospital at night, which isn't atypical. It's kind of always like that. And then during the day, formulating plans for patients, keeping them safe and trying to stabilize them as much as possible. And then working on long-term plans to try to suppress the COVID as much as possible, keep them stable, and hopefully try to put them on a course for the better.
Okay, now when they come to you, they've already been tested, is that correct?
So most people come in and get tested in the emergency department. So oftentimes we'll admit people without knowing whether they're COVID positive or negative. And then other times we'll already have an answer before they come in.
Okay. Now these COVID tests that are given, what is the accuracy rate on those?
So the sensitivity of the test is about 70%. I've heard 70 to 80% quoted. And so it's not great. A lot of times it depends on the operator, because when you take the swab and test someone for COVID, you have to basically take a long Q-tip and put it all the way into the back of the nose, which is really uncomfortable. So if you only get the very opening, it's not as sensitive. And sometimes for whatever reason, people can have several negative tests, even if they do have COVID, which we've seen. But I would say typically if you have 2 or 3 sometimes negative COVID tests, it's pretty accurate that the person doesn't have COVID.
Okay. The other test that I know is out there is the antibody test. And I understand that that actually is not very accurate. Can you talk about that a little bit?
Yeah, so the antibody test is used to see if someone has previously had COVID and recovered and gained immunity. So one of the reasons that people are so crazed about getting it is that theoretically, if you have antibodies to COVID, it means you've already had the disease and you won't be reinfected again, at least not for a period of several months. That's still kind of speculative at this point because we don't have long-term data on this current strand of coronavirus, and we don't actually know what the reinfection rates are. But that's kind of the premise of the test and why so many people want to get it. As far as the accuracy, I've heard that I haven't had it done myself personally, and we're not routinely doing it yet, but we're starting to do it on our patients and also on our staff members as of last week. I haven't done it, but I've heard that part of why it's not very accurate is that it can detect antibodies to other coronaviruses. So if you've had the common cold, and some of the common cold strains are coronavirus, it can pick up those antibodies and say that you have antibodies to COVID when in fact you don't. They're just antibodies that kind of mimic COVID antibodies.
Okay, so then I guess the recommendation is to always be masked.
Yes. Yeah, I would say that I hope that it's good we have the antibody test, because it just means that hopefully it can continue getting better and better and we can get more accurate tests. But as far as how the test would change your behavior or change management, I would say at this point we don't have enough data to say that it should change behavior. So no matter what, I think that continuing to do what we're doing in terms of wearing masks and avoiding large gatherings and washing hands a ton and being careful around other people still holds.
Yeah. So now if you have a patient that has already tested positive for COVID and is having difficulty breathing, I know the first thing they do is put them on oxygen. Mm-hmm. But if it progresses, how do you know when the person needs to go from oxygen onto a respirator?
Yeah, that's a great question. So there's sort of a ladder of ways that you can escalate oxygen delivery. The bottom of the ladder is no oxygen, just like we are now on room air. Right. And the top of the ladder is maximum oxygen on a ventilator or a breathing machine. And in between that, the first step is putting someone on nasal cannula, which is like the things you see in, an ER or whatever show, where it's basically two small flexible prongs in the nose that delivers oxygen. Okay. And you can titrate that. So you can deliver just a little bit or a lot, and it's titrated in liters. So it goes from 1 liter of oxygen per minute to 6 liters. So that's kind of the way that it goes with the nasal cannula. And then from there, you don't have to go straight to a breathing machine. If you need even more oxygen than that, then you can put someone on what's called a high flow nasal cannula, which is basically can deliver even more oxygen. So instead of a maximum of 6 liters, you can do 60 liters of oxygen. You can also put someone on a BiPAP machine, and that basically helps with a couple different problems. It delivers a lot of oxygen very forcefully, but it also helps people get rid of the carbon dioxide in their bodies, which for a small population of people, like for people with COPD or asthma, that may be a problem. And then kind of in between those two, there's something called a non-rebreather mask, which is something that we sometimes put over a nasal cannula. And it's just another way of trapping oxygen and just pushing as much in possible to a person without having to do anything invasive like a breathing tube. If after all those measures, we typically don't use BiPAP, but if after, the nasal cannula with the non-rebreather and then the high flow nasal cannula, if after all of that somebody still is just not getting enough oxygen into their body, which you can test with it's called a pulse oximeter on your finger. It detects how much oxygen is in your blood. If someone's still not getting enough with that, or if they're breathing extremely quickly and look extremely uncomfortable and it's very clear that they're about to stop breathing essentially, then we put them onto a breathing machine because it's the only next thing we can do. Depending on the person, if someone is very young and otherwise healthy, we might do it sooner because the chances of them getting off of the breathing machine are better than for an older person who's sick. Okay. And then in other cases, if someone is fairly elderly and has a lot of underlying conditions and we're worried that if we put them onto a breathing machine, they realistically might never be able to come off of it, then we try to delay as much as possible and try to help them avoid a breathing machine if possible. And then, eventually sometimes have to resort to it. And then, of course, there are a lot of people who, again, typically older people with underlying health conditions, who kind of look at the whole scenario and look at what's going on and say, you know what, if it gets to that point, I wouldn't want to be on a breathing machine. And so in that case, we do everything that we can to keep them off of one. And that doesn't become an option for escalation. And for a lot of people, that's completely fine.
Right. So talk to me about the medication that is typically given to a COVID-19 patient.
Yeah, so there are a couple different classes. One is called Plaquenil, and that's the one that received a lot of press, a couple of weeks ago. We used to routinely give that to everyone who came in. It's an anti-malaria drug. It's also used in lupus, so it has a couple different applications. We used to give a 5-day course of that to anyone with COVID. It's been shown now with clinical trials that it's actually not effective at all, so we don't use it anymore.
Okay.
Other class of medications are anti-inflammatories and anti-cytokines. So we use something called tocilizumab, and we also use anakinra, and both of those are antibodies against the IL-1 and the IL-6 cytokine. And that basically is a medication that's designed to take the inflammatory response of the body and just tamp it down, because oftentimes it's all of the inflammation, even more so than the virus itself, that leads to a lot of the disease and the death that we see in COVID. Remdesivir is another medication, and that's an antiviral. And there's a clinical study that just came out last week that shows that there's actually a 30% increase in beneficial effects using remdesivir. So it's not a slam dunk, but 30% is pretty good. So we use that for, I would say, almost everyone if they need a lot of oxygen. And then the last class of medications are steroids. So steroids are kind of similar to anakinra and tocilizumab in that the point is not to attack the virus. The point is to tamp down the immune response, because again, the body's own inflammation in response to the viral particles is what causes a lot of the damage that we see. So methylprednisone is one drug that we use a lot as far as steroids go. And so we like to start it as early as possible. If someone's going to get it, it's better to start early rather than wait. And we typically give it for at least 5 days in a row and then see how it goes, and may continue it for longer than that. But, like a lot of infection, like a lot of serious infections, a lot of the damage that is done to the body is done by our own immune response rather than by some kind of innate damage by the virus itself.
Okay. So there has been a lot of talk about past COVID patients who have these antibodies in their blood, donate plasma. Have you used any such plasma in the treatment of patients at this time?
We have not. We're not one of the centers that's doing that at this time. I know that some other places are. I haven't seen any data about how effective it is yet, so we'll see. Theoretically, it makes a lot of sense. I think that the efficacy is really going to depend on how soon the plasma is given to patients. If it's effective, I would imagine that you have to really give it right away, because if you wait, the virus has kind of kicked off a whole cascade of inflammation. And so later on in the disease, it's not a matter of getting rid of the virus. It's about stopping this whole domino effect of immune response and inflammation that we see. So we'll see what the data shows. I personally haven't seen anyone give it, or I don't know of anyone who's gotten it. So I can't speak to it too much, but I'll be curious to see what the data shows about it.
Right, definitely. In your experience now for the past 2 months of dealing with this, What age range have you seen in COVID patients?
Yeah, so I would say that I think typically, I would say the majority of my patients have fallen somewhere between 50 and 80 or so. I when I first came into the hospital and I had vacation for a week before I came in, so I had heard some anecdotes about the first cases in New York, and I thought what I was going to be seeing were just all very old people, and that's not the case. So I've had some people who are, some patients my age who end up intubated in the ICUs. I've had some people in their 40s, 50s, 60s, 70s, and up, but to say that it's a disease of older people is really a little bit misleading,
Right.
because it really and truly does affect people from all age ranges and all genders. Yes, of course, the older you are, the harder it is to get through the disease, but it really does affect pretty much every age range.
Right. One of the things that has been highlighted throughout this pandemic is the lack of PPE. How is the hospital handling it, and what happens? I know a lot of these things were disposable. I mean, the mask. I don't know whether you have a visor or you wear glasses or, whatever covering. Can you talk a little bit about the situation?
Yeah, so you always need a couple things. You need an N95 respirator, which is like a mask that is very tightly meshed in terms of the fabric, and it's double layered, so it doesn't let any particles in. It's really supposed to filter out pretty much everything.
Right.
So you need one of those. And then you also need a mask, just a basic surgical mask on top. You need eye covering, so glasses if you wear them, or a visor over your face, something like that. You need a gown that covers all of you, and gloves. So of that, the gowns and gloves you can't reuse. Those are disposable, and you have to reuse them or dispose of them between patients. The N90, the rest of it basically is reusable. So the N95s, we typically will use for about a week and reuse them between patients, and then exchange them when they start falling apart or when they get kind of gross, and you need a new one. And then the surgical mask, you can exchange that. I usually exchange mine once or twice per day. And the glasses you keep, and you can clean them with a Clorox wipe or something like that throughout the day. So some of the PPE is disposable, some of it, you can hang on to. So I think we've gotten a lot better about reusing what you can reuse. When I used to see patients who were being ruled out for tuberculosis, and before this whole pandemic, we would always dispose of our N95s right after seeing the patient. Whereas now we reuse it time and time again because you can, as long as you clean it well between uses. I think just learning to reuse what you can reuse is helpful. And we've also been very lucky that we haven't run out of the gowns and gloves and all of that. And the masks really seem to be the things that are in high demand, and luckily those are reusable.
Right. But the N95 mask, though it is the most effective, it is also a little bit difficult to breathe in. Like, what happens if your doctor, I'm just curious, I don't know, and I don't know if you know the answer, if you're a doctor and you have asthma, how can you effectively work?
Yeah, I think that the most important thing is to limit your time that you're spending with COVID positive patients, mainly because, spread of infection is a cumulative effect. So if you're with someone who has COVID for a minute, your risk of getting the infection is a lot lower than if you're with them for an hour, even though it's just that one person. So we always try to be as efficient as possible when we're in the room. I will often call patients on their cell phone or on the phone inside the hospital room to talk to them before I go in to examine them, just to minimize time spent in the room.
Okay.
And then when I'm not with them, if I'm just in the hall or sitting somewhere where I'm not with a patient, I'll keep my surgical mask on, but I'll take my N95 mask off. And so that kind of helps me breathe okay throughout the day.
Okay. Now, being there from the beginning of this pandemic to today, have you seen an improvement in the curve flattening and going down?
Yeah, I mean, we're definitely seeing fewer people come in as new patients through the emergency department, which is great. So we're seeing fewer new patients, fewer COVID cases, and that's all great. I would say the part that's still frightening is that we have a lot of patients in the hospital who have been there for over a month. And even though they're maybe getting better, they're still there, they're still not, back to where they were before they came in. And for whatever reason, for some people, the recovery is just very, very long. And some people never really clear the infection that well, even a month out, which is puzzling from like a, scientific pathogenesis standpoint, because I don't know how it's possible for someone to keep the virus for so long. But we've seen some people who are still testing positive 5 weeks after they first, got infected. So the curve, in terms of new admissions, new cases, it's going down. We're seeing fewer daily new cases today than we were 2 weeks ago. But we're still really busy in the hospital with people who have the disease and are just taking a long time to get over it. And then you see all of the sequelae that come from even people who do kind of get better and get over their disease. Some of them are now on chronic ventilators through a tracheostomy with a hole into the trachea. And a lot of them have feeding tubes and are just completely debilitated and deconditioned and very much dependent on other people now, whereas before they came in, they were, independent and walking around and healthy. So not to scare anyone or to paint a dire picture, but it really is a very bad disease.
Yeah. Well, I want to thank you for taking time out of your busy schedule and speaking with us. You've really enlightened the viewership, and I thank you. I hope we can reach out to you again in the future.
Thank you so much for having me. This has been a pleasure.
That's all for now. Stay tuned to North Shore Television as we continue to bring you the latest information on this pandemic. In the meantime, we ask you to wear a mask in public, social distance, wash your hands with soap and water, and stay safe.